Hello and welcome to the ILAE Nursing Section webinar series titled Solving Problems in Nursing Practice, Getting Started with Evidence-Based Research. Whether you're joining us this morning, afternoon, or evening, depending on your time zone, we are so glad you're here. Today, we continue our journey of learning and sharing through yet another inspiring set of presentations from our incredible neuroscience nurses from across the globe. I'm Jane from Gaudecker, and I'm honored to serve as your moderator today. My own journey into epilepsy research began with a simple but a very important observation in Western Kenya, where patients weren't returning for follow-up care. And that question, why not, sparked a clinical inquiry that grew into our NIH-funded clinical trial that focuses on interdisciplinary care initiatives to improve access to epilepsy care through community-engaged intervention. Excitingly, today's session is all about that spirit of inquiry. How nurses translate evidence into action, improve outcomes, and lead change. Before we begin, and I introduce our speakers for this webinar, just a few housekeeping notes. All lines will be muted during the presentation to minimize background noise. If you have questions for our presenters, please type them into the Q&A box at any time. And for any technical issues, please also use the Q&A box and our team will assist you. All ILAE Nursing Section webinars are recorded and available on YouTube. Just search ILAE Nursing Section webinars to find past sessions. And finally, on behalf of ILAE Nursing Section, I would like to thank today's presenters very specially for sharing their expertise and passion with us. I want to take a moment to invite all of you, nurses from every region and background, to join the ILAE Nursing Section. We are a global network of nurses who care for people living with epilepsy, and our members work in wide variety of roles and settings shaped by unique economic, social, cultural, and racial diversity of their communities. So whether you are in a large urban hospital or a rural clinic, your voice and experience matter here. And the nursing section is committed to promoting the involvement of nurses from all nations in epilepsy care and in the work of ILAE. And the best part, there is no fee to join. And by becoming a member, you'll gain access to a global network of nurses caring for people with epilepsy, opportunities for professional development and continuing education, and a platform to advocate for better care for people living with epilepsy. Joining is easy. Just visit ilae.org website, or you can scan the QR code with your cell phones. You can see the QR code here on the screen, or email us at ilaenurses@gmail.com, and we can send you the link. We'd love to welcome you into this supportive community. Now that we have explored the benefits of joining the ILAE Nursing Section, let's turn our attention to the objectives of today's session. Our speakers will guide us through understanding where evidence-based research fits within the broader spectrum of nursing methodology, learning how to begin forming a clinical question, and seeing a practical example of how the research process can be applied in real-world epilepsy care. And now it is my honor to introduce our speakers for today's webinar. Dr. Janine Winterbottom is a consultant nurse in epilepsy and leads the epilepsy nursing service at the Wharton Center NHS Foundation Trust in Liverpool. With over 30 years of experience, Janine holds an MSc in Advanced Nursing and an MA in Healthcare Ethics and Law, focusing on ethics in epilepsy drug development. She received the Sir Desmond Pond Fellowship and completed her PhD. She led 2 key quality improvement projects on shared decision-making and transition pathway for young patients. Recently, she completed an NIHR research for patient benefit grant, establishing core content for preconception care in women with epilepsy. Her presentation today is titled Epilepsy Nursing Research to Inform Evidence-Based Practice. Our second presenter, Dr. Gena Bergvall, is an advanced practice registered nurse and director of evidence-based practice at the National Institutes of Health Clinical Center. She is a triple board certified as an adult gerontology acute nurse practitioner, adult gerontology clinical nurse specialist, and clinical nurse specialist acute care. She serves at the NIH Clinical Center. She co-developed the NIH Nursing EBP Fellowship and has contributed to national CNS and neuroscience certification programs. The presentation today is titled Thinking Like a Nurse, How to Translate Evidence into Clinical Practice. Unfortunately, Dr. Bergvall is not able to attend in virtually due to lapse in federal funding following the expiration of the annual budget on September 30, 2025. While certain federal activities have ceased, the clinical team continues to see patients and remain open to support clinical research. So please send your questions to Dr. Bergvall at ilaenurses@gmail.com regarding her presentation, and we will forward them to her. And last but not the least, Dr. Matilda Mogh is a clinical nurse specialist in epilepsy at Astrid Lindgren Children's Hospital. She is also a PhD candidate at Karolinska Institutet, and her research focuses on epilepsy surgical evaluation. She explores prognosis, risk factors, and patient experiences with a particular emphasis on leveraging artificial intelligence to identify more candidates for surgical assessment and to improve post-surgical outcomes. Her title for today's presentation is Turning Clinical Insights into Research Projects, a Doctoral Journey. And with that, let's get started with the presentations.
Jane, people can't hear you. Can you check your audio?
We're sorry, the ILA team is working on trying to restore the audio. Please bear with us. In the meantime, if any of the audience has burning questions that you want to start putting in the Q&A, please feel free to do so.
I'd like to thank the International League Against Epilepsy Nursing section for inviting me to present on epilepsy nursing research informing evidence-based practice. I'm Janine Winterbottom. I'm a consultant nurse in epilepsy working in Liverpool, UK. I've no conflicts of interest for this session. However, I have vested interests as I hold a senior clinical research practitioner grant, and I'm also co-theme lead in the reproduction and hormone theme of the UK Epilepsy Research Institute. My focus today is to present an overview of research process, informing evidence-based healthcare and positioning nurses in capacity building. Why? Well, it's a gold standard. So it's a gold standard for delivery of safe and effective patient-centred care to have evidence-based practice. And its aim is to remove, where possible, the subjective opinions, unfounded beliefs or bias from decisions and actions in our delivery of care. It can help guide decisions we make about healthcare to be based on the best available, current, valid and relevant evidence. And it's being able to deliver evidence-based practice that makes us safe and effective. Without evidence, our care could be at best ineffectual and at worst dangerous. So evidence-based nursing really brings together that integration of evidence, best research evidence, along with clinical expertise and patient values. And it's to improve the lives of individuals with epilepsy. It needs to be clinically relevant, efficacious and safe, and to be applied within every patient contact and health decision as valid information to assess diagnosis such as is it a seizure, to prognosticate on assessing risk, and to identify the best and most appropriate interventional therapy or preventive strategy. Integrating epilepsy nursing practice relies on us critically thinking and using our knowledge and experience. It's that ability to apply clinical skills using experience and knowledge of epilepsy to rapidly identify the patient's health state and diagnoses. We're assessing risks and benefits of potential interventions and gaining understanding of the patient's personal values and expectations, including those clinically relevant outcomes that we might use to measure intervention effectiveness. And it's integrating that knowledge and experience with patient values. Understanding patient values is crucial, not only for our registration or license to practice, but also from an ethical standpoint. And it's often fundamental in the research funders as a requirement. But nursing research and understanding that integration of patient values can optimise the clinical outcomes and improve quality of care and quality of life for individuals living with epilepsy. It can inform decision making by assessing those preferences and concerns, such as what's important to the patient and what matters. But using this within the research gaze, we can see how research priorities can be drawn together involving patients and stakeholders, such as within a James Lind Alliance, and very much integrating patient values within the research cycle. And this was demonstrated by a schematic developed by the National Institute of Health Research, placing the research process with patients centred and really looking at that knowledge mobilisation considered throughout the whole of the research process in which a patient might engage. But we can place epilepsy nurses within the centre stage also, and they're involved in every stage, such as identifying those topics of importance. We might not necessarily hold a grant ourselves, but we might be involved in defining those outcomes that matter. We may be involved in gaining data and recruitment, and we might be involved in dissemination or implementation of study findings. And finally, we may evaluate those study findings and recommendations and move towards identifying fresh topics. So in identifying those topics and problems, we are using our background and foreground knowledge. We're broad, aware of the matters of the condition and the challenges faced by a patient population, such as with stigma, but we're also aware of the specific, those foreground questions. And we're ideally positioned to locate best evidence in a systematic search using our trusted sources of data and using review processes such as Cochrane to identify systematic reviews. And we can also use our evidence-based practice guidance and the recommendations raised within. But what is valid evidence? It has to be clinically relevant, efficacious and safe. So clinical appraisal techniques such as GRADE ideally support us in reviewing the certainty of evidence and supporting transparency in our healthcare decision making. But we need to be using developed and systematic processes that have relevance to the stakeholder priorities. In framing our research problem, we need to be precise as it drives our methodological decisions. And a strong problem statement needs to identify those gaps in knowledge, what's unknown, unexplained or contested. And we need to position our study within the specific context, the who, the what, the where and the when. And we need to clarify the purpose of the study or problem that we're exploring. Is it exploratory or are we evaluating a practice already in place? And this could be evaluating current guidelines and how they're applied in a particular context. And we're translating that into a research question and maybe a hypothesis. And that'll often relate to that research methodology and moving from theory to observation or from observations to theory. And that's maybe positioning us with a more qualitative or quantitative approach or inductive or deductive approach. So we're often place at polar opposites, qualitative and quantitative research, where they really are co-dependent on each other, and it very much depends on whether the study is exploring such as topics not well defined, understanding patients' attitude to a new intervention, for example. In descriptive research, we may be understanding complex phenomena, gaining insight into carer experiences. Or in an exploratory research, we're gaining those relationships and causation, and this might be where we're beginning to hypothesize, investigating adherence in patients' treatment with A versus B. B might be the established treatment. And in predictive research, we might be forecasting future outcomes, predicting the likelihood of patient seizure freedom, for example, in certain patient populations. And this will lead us to develop those questions, whether from a quantitative approach, such as what is the effect of, for example, telemedicine in nursing, as a nursing intervention on adherence, rates of adherence, or it may be in identifying the needs of young carers and understanding the complex phenomena of being a young carer of a parent with epilepsy. So we're matching method to question, and this aligns with our research methods and our objectives and questions. In surveys and questionnaires, we're often looking at quantitative data in large scale. We're measuring patient satisfaction, for example, in epilepsy nursing care across multiple regions. In interviews and focus groups, we may be exploring those in-depth qualitative insights, such as those understandings of risk. In experiments, we're looking to test the hypothesis and establish causality. So we may be investigating the impact of an intervention. I was that intervention in an RCT back in the 1990s when I established the epilepsy nursing service at the Walton Centre in Liverpool. And Elaine Warren was leading on a randomised controlled trial of me as the intervention in one arm of the trial compared to those people who were having care as normal, which at the time was a non-epilepsy nurse care. Within case studies and cohort studies, we can look at these either as prospective or retrospective, and we can look at a single group or cases in a particular context or population, such as analysing the impact of anti-seizure medicines prospectively in those women who've taken them through pregnancy. And in secondary data, we may be leveraging those existing data sources, those routinely collected data, analysing those trends and associations in differing epilepsy populations. So the research journey for myself started with a question of how do women prepare for pregnancy. My rationale was to reduce those health inequalities that result in those increased risks of adverse pregnancy outcome. And it was exploratory, as in the early 2000s, there was little known of how women make decisions about conception and what might influence their pregnancy planning. My methodology was really bringing two ways of knowing, that of the medical model and social sciences, as women live outside of the clinic and make those decisions about conception and having pregnancy outside of the clinic room, although they may come and ask us questions. So it was looking at how this may be viewed and interpreted in the data I wanted to collect, and that focused my endeavours and methodology into interpretive phenomenological analysis, and I used that within a qualitative research method to select reproductive women throughout their life cycle and collect data using techniques of in-depth interview, focus group and clinic observations. I was focused on ensuring a protection of harm for the participants, as this was a sensitive and delicate topic. And we were looking at finishing that research cycle in a quality criteria where the data produced was analysed and measured against the research questions. And it was really to meet those study objectives as an obligation to participants and the sponsors. So epilepsy nursing research is important for capacity building, not only in epilepsy nursing research itself, but in epilepsy research in general. I think we're ideally positioned to add value and create an evidence of benefit of our interventions. We've got the community of nurses as well within the epilepsy nursing research that we mustn't forget as part of that wider ecosystem where we can look to develop multidisciplinary collaborations and research partnerships. And it's been aware of that research, research environment in which we can see where we're positioned as individuals and organisations. So learning of your individual organisations' priorities. Working together, generating and disseminating our knowledge base, and also working to create new knowledge for better health outcomes. So in conclusion, our role is to build capacity. I think epilepsy nurses have an ideal position to identify questions. They may conduct research in their own right, but they can definitely shape an evidence base of practice, and we can advocate for change. I'd like to thank you. And here are my references and some useful links. Thank you.
Good morning, afternoon, or evening. Today we'll explore how neuroscience nurses, especially those in epilepsy, translate evidence into bedside action. Thinking like a nurse means connecting research, reflection, and compassion to improve overall nursing care and best practice outcomes. Here is my disclaimer. This section of the education series will discuss how to cultivate EBP through the spirit of clinical inquiry, differentiate between quality improvement EBP and research, outline the steps by using the EBP nursing process model, and identify strategies to translate evidence-based practice into clinical practice. Evidence-based practice leads to evidence-based decision-making at the bedside, and most clinical practices require some sort of evidence-based practice to translate best evidence and research into daily practice and the orchestration of every day. A problem-solving approach integrates the conscientious use of best practice, best evidence within the literature, in combination with professional expertise, as well as patients' preference and values to make clinical decisions. This leads ultimately to best outcome to best care. To have EBP practice, you must have an EBP organizational culture that not only supports and encourages clinical inquiry, it is key to sustain and implement EBP in daily practice. Clinical inquiry, therefore, is a process in which clinicians gather data using narrowly defined clinical parameters to appraise the available choices and treatments to find the most appropriate choices of action. To do that, you do need a strategy or utilized in most EBP processes, which is the searchable question. And that becomes the basis of your clinical inquiry as you explore databases for the best evidence. Further terminology, and to make sure that we all understand the difference between research, EBP, and quality improvement is important. And you can have one or a combination of all three, and you really need all three to have best practices. For example, research generates a new evidence, and this is the question. The question that we usually ask is, what is the best thing to do? Whereas EBP is translating that research into and implementing the evidence into practice. And so you ask the question, are we doing the best thing? Quality improvement comes into the into the frame by asking, are we doing the best thing right and continuously? You constantly need quality improvement to understand if we are doing the right processes, and you need EBP to implement all new and best evidence into practice while integrating clinical expertise and patient and organizational preferences. So in essence, the culture of EBP becomes the DNA of your organization, and you not only have EBP or do EBP, you become EBP and within your nursing practice. There are 5 broad categories of EBP models that helps you understand EBP models and frameworks. Most commonly in nursing, we have process models, and that outlines the steps of how we do EBP evidence-based practice. Most commonly, you see Iowa, Johns Hopkins evidence-based practice, or the 7 steps. Determinants identify barriers. Classic theories are the ones that we well know in nursing science and nursing practice. For example, the diffusion of innovation. It defines how change or explains how change spreads throughout the organization. Implementation was founded within implementation science, and that adapts theories to provide explanations on how to implement. The most common one that we see in EBP nursing is advancing research and clinical practice through close collaboration, or the ARC model. And evaluation frameworks measure the impact and reach. A common framework there is the REAIM theory. All EBP starts with inquiry, with noticing variation. We often ask, search, and act. Curiosity is often the first step of EBP to provide safer care and outcomes. Early in the development of evidence-based practice, the basic skeleton process was developed in 1997. This foundation influenced the study of evidence-based practice, and although it looks simple, each area includes a vast number of ways to review the literature and integrate the evidence. From this, a whole new science was created, implementation science, which is dedicated just to implementing evidence. A recent scope review in 2023 identified 19 different types of evidence-based practice models. The ones that we will focus on, though, will be the nursing model, which is seen here. These are pretty well-known practice models that I highlighted earlier. Choose one that fits your environment. Process models such as the Iowa and Johns Hopkins and the 7 steps really helps understand the practice, but there are more steps and toolkits behind those models that can help you help even a novice person in evidence-based practice implement it EBP within their clinical practice every day. All process models, as I mentioned, have a searchable question. The most common one that is well known is the PICO, sometimes with a T, sometimes without the T type of question. And that stands for patient intervention, comparison, and outcome, and T is time. There are separate categories that help you frame the question. And there are intervention questions, prognosis, diagnostic, and etiology and meaning. They all help identify and may be slightly different on how you might frame the question. But make sure that the PICO doesn't become the whole project. It is just a strategy to help find keywords when you're looking through the data. So so when you do that, you may have just one PICO question initially, but at the end of a EBP initiative or project, you may actually end up having 4 or 5 PICO questions as you move forward. And it's okay to have more PICO questions because that provides the framework and the roadmap on how you found your literature and your evidence initially. I'm highlighting the ARC model, and this is an implementation theoretical model because it's a macro view of how you can implement evidence into your organization. The ARC model focuses on mentorship, organizational readiness, and the belief in EBP to have a sustainability of evidence-based practice within your organization where you want to integrate EBP. In neuronursing, we can use this to train, for example, seizure response champions, mentoring who help their peers and their colleagues apply new protocols. With this model, it has the stepwise fashion and toolkits within the ARC model with the 7 steps and an implementation and sustainability framework, which was formulated and modified from the parish model, which also provides tools on the EBP process from start to finish, or step 0 to step 6. So what does the science tell us about EBP? Well, education alone does not change practice. Systems and mentorship do. We need a shared framework or a shared mental model and measurable impact and leadership alignment to have successful EBP implementation. So you can think about EBP as a science and nursing as the art. Science tells us what to do, and nursing tells us how to do it. And a framework will tell you how to sustain the whole practice within your organization. This strategy of a force field analysis helps define barriers and facilitators within your organization, but you can also utilize it to help find the driving forces, the facilitators, and the barriers or the refraining forces when you're dealing with a pain point or a clinical inquiry issue. The take-home point from this article, from this qualitative analysis, shows that successful EBP implementation depends on strong leadership, resource support, and a culture that empowers engagement. Without these, the barriers overcome the facilitators, and you have gaps and momentum for change. Duff et al. In 2020 showed facilitators like strong leadership and positive EB culture and barriers like resources and poor engagement as the overarching description of a poor EBP environment. In neurology units, barriers might include competing priorities, limited protected time, or absence of data feedback. So what barriers could you remove tomorrow or in 6 months or within years, or 1 or 2 years? What can we put on your strategic plan for your organization to help EBP integrate into your organization? Thinking like a nurse framework is key to advancing EBP. Clinical judgment is more like a process, and traditional models like the nursing processes are too linear. So you have to think about it in a real-world dynamic care. This helps integrate EBP and facilitate evidence-based practices initiatives at the bedside. Nurses are known to observe and then interpret and respond. When they notice the gaps in evidence at the bedside, this helps fuel and respond to integrating evidence-based practice through the entire organization. So utilize the nurses to empower evidence-based practice and clinical change. With the nursing audience in mind, motivate them with nursing pride of their practice and advocating clinical inquiry to fuel their practice. Understanding the difference between process and outcomes. Encourage curiosity and link it to their professional pride of nursing. Inquiry fuels value-based care, improving safety and satisfaction, and clinician well-being. When nurses measure their own impact, they transform from implementers to innovators, and EB becomes their superpower. Without inquiry, you see the practice deviations in your organization, and then you also see that healthcare diffuses slowly, and research and practice never meets the bedside. So the overarching framework is to build those core building blocks to build EBP within the practice. The take-home points here is that EBP is a dynamic process. It's not a project. You must live EBP at your bedside and integrate it into the EBP organization by starting with making EBP as part of your mission and vision. Nurses are uniquely positioned to bridge evidence and empathy. Sustained inquiry improves outcomes and professional satisfaction. Close reflection, like thinking like a nurse, means turning evidence into action with compassion, and EBP empowers nurses to question, innovate, and leads. Frameworks like ARC and Tanner model will help translate science into action. And epilepsy care improves when we align curiosity with structures, when nurses and organizations truly think like a nurse. Thank you, and here are my references.
Hi everyone, my name is Matilda Mogh and I am currently working at Astrid Lindgren's Children's Hospital in Stockholm, Sweden as an epilepsy clinical nurse specialist with a focus on pediatrics. For the past 10 years, I have been involved in the clinical care of children living with drug-resistant epilepsy, and I have had the privilege of meeting and supporting them and their families. Over the past 4 years, I have also been pursuing my PhD, and today I would like to share how my clinical experiences have evolved into a doctoral project and what that process has looked like. I'm truly honored to be here today, and I look forward to discussing the power of nursing research and how evidence-based approaches can help us bring new knowledge into clinical practice. A big part of my clinical work has been in the Epilepsy Monitoring Unit, the EMU, and as an epilepsy surgery coordinator. In these roles, I have gained valuable experience caring for children with drug-resistant epilepsy throughout the epilepsy surgery evaluation process. Long-term video EEG monitoring is considered the gold standard for evaluating epilepsy. It plays a crucial role in pre-surgical assessments, helping us localize the epileptogenic zone. During their long-term video EEG, children stay in the EMU, where continuous EEG is combined with 24/7 video recording in a designated area. The hospital stay can range from a few days to several weeks, depending on how many seizures need to be recorded. For most patients, the first seizure is captured within 48 to 72 hours after admission. But for those with infrequent seizures, we sometimes use seizure induction methods such as sleep deprivation or tampering anti-seizure medications. We know that children often find the hospital environment challenging. In hospital, they usually rely on a few coping strategies, for instance, leaving their room, visiting the play therapy, or going outside for some fresh air. But during long-term video EEG, these activities are restricted for an uncertain period of time, which can be very stressful for the children. They may feel anxious, confused, and that their sense of autonomy is being threatened. As you can imagine, having to remain still and stay within a limited space can be difficult, especially when combined with sleeping in an unfamiliar environment and disruptions to their usual routines. Despite this, we actually know very little about how children experience long-term video EEG monitoring. Their perspectives have not been systematically studied, and there is no empirical evidence available on this topic. And this is why I became really interested in exploring how children themselves experience undergoing long-term video EEG monitoring. And as I mentioned, besides working in the EMU, I also work as an epilepsy surgery coordinator. I have met children experiencing up to 40 seizures per hour, and I have also met children and their families after surgery when the children are seizure-free. We know from studies that early diagnosis of drug-resistant epilepsy, referral to a specialized epilepsy center, and access to early surgery are all critical factors in achieving seizure freedom. In 2019, the Swedish National Board of Health and Welfare published guidelines for treatment of epilepsy. The purpose of these guidelines is to ensure that both children and adults receive the right follow-up and treatment. However, the report revealed national differences, both geographically and demographically, in who is offered an epilepsy surgery evaluation. Preliminary work for the guidelines also suggested that Sweden should double the number of epilepsy surgeries based on how many people are living with drug-resistant epilepsy. I realized I really wanted to help more of the patients I see in my clinical practice who are living with drug-resistant epilepsy. Based on knowing that Sweden should double the number of epilepsy surgeries, I started wondering how to find more suitable candidates for epilepsy surgery evaluation. For that, I thought I needed a lot of data, and Sweden is known for having one of the most comprehensive health register systems in the world. These registers have a long history, high coverage, and bring together many different types of health data. They contain deep information on conditions, treatments, and outcomes, and they are used for everything from public health planning to research and quality monitoring. As a self-proclaimed math geek, I became curious about the possibilities of using data from these registers together with artificial intelligence. However, knowing what the research shows and have seen firsthand the difference surgery can make, I was left with one key question. Can we find a systematic way to identify more patients with drug-resistant epilepsy who should be offered an epilepsy surgery evaluation? So, I had identified these two research questions. First, how do children experience undergoing long-term video EEG monitoring? And second, can we find a systematic way to identify more patients with drug-resistant epilepsy who should be offered an epilepsy surgery evaluation? But I also asked myself, how could I possibly find answers to these questions? I knew I wanted to use different techniques and methodologies, and I thought that maybe talking directly with patients and using artificial intelligence in some way could lead to answering these questions. But first of all, I didn't know much about how to build a research project, and at the same time I was working full-time as an epilepsy clinical nurse specialist, and I was also the only epilepsy surgery coordinator at Astrid Lindgren Children's Hospital. So as you can imagine, it was quite challenging to find the time to begin a research project. That's when I decided to talk to my head of nursing to explore how I could start developing my research ideas within my clinical role. And after having several conversations with my head of nursing, I started talking with the physicians I worked most closely with. They were all really supportive, and with their encouragement, my doctoral project slowly began to take shape. And today, these are the 4 studies that make up my doctoral project. It is clearly based on my clinical experience working in the EMU and as an epilepsy surgery coordinator. The overall theme of the project is drug-resistant epilepsy and the epilepsy surgery evaluation process. Just as I had hoped, I have been able to combine different methodologies. The project includes 3 distinct approaches involving direct communication with patients, as well as a strong mathematical component. You might remember the first question I wanted to answer. How do children experience undergoing long-term video EEG monitoring? And that became this study, and it is the first study I have published together with my supervisors. So, take-home message. Use your clinical experience. What do you find interesting in your daily work? What questions come up while you are at your job? Talk to your colleagues. Reach out to others around you who are experienced researchers and ask for guidance. They genuinely want to help. And once you have your research questions and that supportive network cheering you on, it's time to take the first step on your journey to become a researcher. Choosing to pursue a PhD has been the best decision of my career, and I can promise you, every challenge along the way will be worth it. Thank you for listening.
Thank you for those wonderful talks. I want to thank all our presenters, and I encourage our participants to type your questions in the Q&A box. And I would now like to invite our panel to come back so that we can open the Q&A session. If you can turn your video on. All right, great. So while we wait for any questions the participants have, I do have a couple of questions while we wait. So as you mentioned in your talk, research generates new knowledge. EBP translates that knowledge into practice, and QI ensures it's sustained. And many are confused about these 3 methods of addressing clinical gaps. Would you be able to share any specific examples from epilepsy care where all 3, like research, EBP, and QI, has worked together to close a clinical gap? I would ask Dr. Winterbottom and then Matilda to respond.
Yeah, that's putting me on the spot. Yeah, I mean, I think that it is difficult to actually bring all 3 together. I think they work more in almost like in a round. So one is feeding into another, and so I think it is a more cyclical approach as opposed to things all going together. I think one of the problems we have in moving directly into the implementation side of things is we have an idea. We think it's really good. We get some evidence, but what we are not necessarily doing is maybe talking to the patient population or seeing it from within a different perspective. And if we're looking at going straight into delivery, that's where we can not be meeting the needs, and we're also using resource or adjusting practice without the evidence base. So what we need to do is see where really we are working in that circle of questioning constantly, bringing that search of the evidence, seeing where gaps are that may then need and lead to research questions, and then in that process looking back into our practice. But we can do that within practice guideline, so we can see where we have a role in using that analysis of, are we meeting, are we reaching a standard? Are we benchmarking ourselves against what is in recommendation? And that then can lead us to, well, why are we struggling in this area? And that might itself be the project that you then see as your research. So I think it's looking at all three, but I would struggle to say within one project all at the same time. Sorry for that. Not being able to directly answer that question.
Thank you, Janine. Matilda, do you have anything more to contribute?
No, I agree with Janine, and I sometimes think that maybe the time process from when we have the results from research and the time when we can implement it is a bit too long. I think it would be nice if we could find a way to collaborate the two aspects, research and clinical practice, a little bit, so we can make the process a little bit quicker.
Mm-hmm. All right, great. Thank you both. We do have one question in the Q&A box. Matilda, you mentioned a little bit about the barriers you faced in, conducting research. And the question here is, in your countries, how do institutions support nurses in implementing evidence-based practices? Do they create committees, for example? Do they provide financial support? I think we would like to hear from both Sweden and UK.
It's actually a great question. I would say that in Sweden we don't have like a support system for nurses who would like to perform research. It's just that you need to find the right persons, and you need to have a great, for me, head of nursing who supports me. Otherwise, I would be still struggling to start doing my research. So it's an important question to raise, but it's hard to find a good answer to it.
Janine?
Yes, thank you. And it's a good question. And I think it's one that I've certainly been asked and within my own organisation as well as from others. And I think sometimes the financial support is where we see a real barrier, because we can see that, and I think a point that Matilda raised within her presentation of where you're working full time, you've got a good idea, you've got people who may be supporting, but how do you move it forward? And the funding often comes in once you've submitted, say, a proposal to a research grant, or you're on a fellowship grant where you're having some of your time bought out of clinical practice. And your research institution needs to look at whether how they value the nurses. I think there is a move forward. There's certainly a move forward within my own institution to really see the value. And I think one of the key statements is around that non-medical research model. We've seen a very big focus in our education and our placement of staff in that clinical academic role very much is favoured in a medical model, and it doesn't stop us exploring it from a nursing perspective, but we do need to link in with those institutions, our academic institutions, our health organisation, our healthcare organisations, such as within the NHS, and we have grant streams that we can approach into and apply. But I think it is a competitive process, so you have to be rather thick-skinned, get used to rejection, but also get used to fighting your corner. And I think that's, as Matilda, I think your point about finding your allies, finding who will support you, both medical, within your nursing structure, and sometimes you have to look outside of your organisation to find that support, but you will need ultimately to be within your organisation to affect some of those changes. But yeah, we shouldn't see it as a barrier. These are opportunities for us to see a development, and it's a capacity building. We need to raise that. You know, we talk around a succession planning, for example. How do we build our nurses for the future? How do we make sure that there's more Matildas in the future looking at epilepsy research and being really passionate about supporting those children with drug-resistant epilepsy? Well, the only way is to make sure that those future nurses joining the institution that you're working in can see your example. Yeah, so that's how I'd approach that. Yeah.
Thank you very much. That was comprehensive, and I think we covered a lot of areas there. I was also planning to ask on capacity building after this, but Janine, you have talked about that as well. Thank you so much. Given that we don't have any other questions, I want to encourage our participants to kindly use the survey link here to complete a survey. Your input will help us make these webinars more valuable. So please use the QR code on the screen or use the link here to complete the survey. And also, we thank all of you for joining us today, for being part of this important conversation on nursing research and evidence-based practice in epilepsy care. And before we wrap up, we want to say we need you. If you have interest in speaking at a future webinar or contributing to the development of our nursing section webinars, we'd love to hear from you. And this is your opportunity to share your expertise, your stories, and your passion with a global community of nurses. So please reach us at ilaenurses@gmail.com. Thank you all.